The first speaker for the next session, which is the ISRS session, is going to be none other than David Chang, who's going to be talking to us about capsular complications. So David, I'm sorry that we are late, but I know you have things to go to, and we'll start quickly. Let's go, as soon as you can.
All right, well, thank you very much. So I'm going to talk about the problem of premium lenses with capsule tears. May I start? Anytime, if you could. Okay, great. And I'm going to do this by showing 7 cases. These are my relevant disclosures. So this is kind of a unique problem, because even if you rupture the capsule but prevent vitreous prolapse, you put a 3-piece in the sulcus, get a 20/20 result, this is a bad result for many patients because they decided they wanted a premium lens. And they will have trouble for the rest of their life accepting that they never got that lens. It's worse if you already put in an EDOF or a trifocal in the other eye that they're happy with. And so they could be very, very unhappy, and you can refer them, and there's not much we can do about it at that point to go back and try to put that lens in. So I'm going to say something a little controversial, and that is I think this is where we can be more aggressive than usual if you think there's a reasonable chance of putting that principal lens in. So here's 2 situations where I'm putting in a trifocal, it's a panoptics with a single radial anterior capsular tear. There's no wraparound. In the left-hand side, it's easy because it's a spherical one, and I can have the haptics 90 degrees away from the tear. In the bottom one, though, the toric axis is right where the anterior capsule tear is, but because it hasn't wrapped around, you actually have a fornix there, and because the haptic is going to unroll and unfold slowly, you can get this aligned. All right, well, this next one is tougher because it's a high-power monofocal toric. I can see debris and Berger space, and it's a posterior polar cataract. I stabilize, come out, you can even see the posterior polar opacity next to the break. But it's a high-power toric, and I'm going to need to rotate it because a T5 has to be on the right axis. So I'm going to try to grab the opacity and try to round that off, because if I can convert to a posterior CCC, and there you can just follow it right over here, and it's very thin. So my favorite forceps, this is the Seibel capsule forceps from MST. And what's beautiful about this, I can come through a side port. I don't have to go through the main incision where I would burp out viscoelastic shallow of the chamber. I might have vitreous prolapse. And I just keep putting plenty of viscoelastic in there. We don't have to aggressively remove it. And now with that T5, as long as I get the haptic in between the anterior posterior capsule, now I know I can rotate it and not have that tear extend, because obviously it does no good to put this in and have it be in the wrong axis. That's a zepto capsulotomy, but now you can see the posterior CCC. So there's an example of the posterior CCC. Now here, there's a rent on the temporal side, and I can't convert it, but there's vitreous prolapse to the incision. So the pearl here is I have to go through the pars plana, because if I go through and do the anterior vitrectomy from the limbus, this is just sweeping the incisional area, I run the risk of expanding that rent so that I don't have much posterior capsule left. Now the other eye has a high-powered toric, as you can see from the topographies. This eye is scheduled for a T6. I can't get away with LRIs. And so even though the rent is where the haptic has to go, because it didn't extend, and I'm going to see what happens. The worst thing is if it decenters, I could just take it out right now and put in another lens, put in a monofocal. But here I have to have it lined up so that haptic is sitting over there, but there's enough support that this lens remains stable for well over a year of follow-up. All right, now this is a little tougher. This is a woman wanted a panoptics with a T3. This is a wraparound tear. So I get that last piece out, and there's so far no vitreous presenting. So I'm going to do a dry aspiration of some cortex. The wraparound is on the temporal side. It's wrapped around, and that's why I have in the horizontal axis this big tear. Now, this is not something I'd normally be that aggressive about, but this woman really hated glasses, really wanted a bilateral, multifocal, and if I can't get this, I don't know what I'll do with the other eye. So let's give it a try. So there's no vitreous prolapse, so that's helpful because now I have some support, the hyaloid, and I have to get each haptic in there. It's a toric with the rule of astigmatism. So even though the posterior capsule has the rent in the middle, the anterior capsule has a wraparound, it's going to work out. Now, it might not have it. This might decenter, in which case I go back, I take it out and put in a 3-piece in the sulcus, maybe a light adjustable lens possibly with consent now. But my point is, if you think there's a chance it would work and the patient really wants it, you know your patient, and I put myself in their situation, why not take a shot at it even though you're not sure it's going to last? This is a case with a posterior polar cataract, again, expecting a panoptic toric. We did talk about the fact that it might not work. There was a big rent in the posterior capsule, right where the posterior polar cataract was. So we do all the cleanup, and at the end we still have a rhexis intact, but half the posterior capsule's gone. Similar situation. Knowing the patient, I think she's going to be okay with me trying, and you have to tell the patient afterwards in case something went wrong. I thought about what I would want if I were in your situation. So this is reverse optic capture. I've done a vitrectomy. The lens is in the sulcus, and then each haptic, one at a time, has to be dropped into what would normally be the capsular bag. So each haptic is under the rhexis, but the optic lies anterior to the rhexis. And if you've done reverse optic capture before, you'll know you get sort of a rectangular opening. The axis is at about 165, 170. So there you see where the marks are. The digital alignment doesn't show up on this video. And fortunately, it's going to center well because the rhexis is centered. And I've got the toric axis aligned. And again, if it doesn't work out, I can go back and take it out later. Finally, a case where I was going to have a toric vivity, and this is another wraparound. And you will someday have, but we now have the light adjustable lens in the United States. And this is a wonderful option because it's a 3-piece lens and it's a custom toric lens. And it has the LAO plus has some extra convexity on the surface, so it acts like an eat-off lens. And so this is a situation where I can't remember if the patient was all right, that I could talk to her on the table. This is sometimes the problem with the consent. But what I'm doing here, if we can just clear that, it's almost over. If we can, we've got the lens centered in the sulcus, and the rent is to my right, so I'm putting the haptics 90 degrees away. I tuck the optic under the remaining edge, and that lens is centered, and we can now go back and adjust it and create a custom toric. So the pearls are ACC tear, you can be quite aggressive. Posterior CCC can really bail us out. Think about a posterior pars plana anterior vitrectomy so you don't expand these tears. Reverse optic capture, really good. And we can have this additional option of the LAL. All right, thank you very much.
Thank you, David. And while Doug Koch, who's going to go next, while he's setting up, I just have one question, I think, and I'll obviously take audience if they need to. But one question to you is there a size of an intraocular lens before you do the reverse of the capsular rhexis, before you do the reverse optic?
So reverse optic capture, you'd like it, certainly a little bit smaller than the optic, so 5.5 works. I've done it where sometimes they have to enlarge the rhexis just a little bit to be able to do that. And of course, it has to be centered, you know, so if it's off center, the converse is if it's too large, it's just not going to stay. And sometimes you'll try it and you can't get it to stay, you have to take it out.
And I'm sure the audience might have one question. If they do, it'll be the right time to ask David because he has to go for another session.
Another session, yeah.
Okay, awesome. Thank
Okay,
you so
good.
much,
Thank you.
David.